is 6 o'clock, and so welcome to this meeting of the Adult Social Care, Health and Communities Overview and Scrutiny Committee. You're all very welcome. I think we'll start with a round of introductions so we all know who we are and why we're here. So that will also enable those joining us online to know who we are. So I'm Councillor Bob Purser, and I'm chair of this committee. Shall we go to my left, Richard?
Thank you, Chair. Richard Woods, Democratic Services Officer for the Council.
Wendy Binmore, Democratic Services Manager for the Council.
Alison Eastwood, Chair of WNC, but also Ward Councillor for Rural South.
Councillor Fiona Baker, Ward Councillor for Brackley.
Rosie Herring, Ward Councillor for Middleton Cheney.
Susan Ward, Councillor for Boston Vic.
Councillor Susan Gaskell, Ward Councillor for Martin.
Ashley Leduc, Assistant Director for Integrated Commissioning in the People Directorate.
Councillor Laura Coos, Ward Councillor for Nin Valley and Cabinet Adult Care and Public Health, so I'm here to support.
Cameron Emery, Ward Councillor for Headlands.
Adrian Cartwright, Ward Councillor for the Headlands.
Good evening, everybody. My name's Hayley Adkins. I am Councillor for Duston and also Vice Chair of this committee.
Evening, David Johns. I'm Director of Public Health.
Good evening, everyone. Neil Cox, Director of Adult Social Care.
Excellent. Thank you very much. Do we have any apologies for absence, Richard?
Thank you, Chair. We do not, but we're aware of traffic issues in the area, so some may be late. Thank you, Chair.
And do we have any declarations of interest on any of the items that are on tonight's agenda? Okay. Can I therefore sign the minutes of the meeting held on the 14th of October as a correct record of that meeting? Is that everyone agreeable to that? At some stage, no doubt, minutes will arrive and I can actually sign them. Chair's announcements. I have this evening no announcements to make, so we can therefore move on. Oh, right. Oh, right. So I do have 3 announcements to make. One is that we're being broadcast on YouTube, so do speak into your turn it on and speak into your microphone clearly. Secondly, we're not expecting a fire drill, so if the alarm goes, we will need to evacuate, and no doubt we're in Richard's capable hands and nobody more capable. And can we make sure our devices are turned on to silent as well, please? So that having been done, we can move on to the substantive items on the agenda. And so we've got 3 items that we're looking at tonight. One is the Adult Performance Monitoring Report. The second is looking at workforce planning. And then the third will be looking at prevention, which David is going to lead us on. So tonight we're very much an adult services focus on our agenda. So Neil, take it away, please.
Thank you, Chair. So committee members would have been... Sorry about that. Committee members will have been provided with a report in relation to adult social care performance and performance indicators. Probably just to give an overview in terms of the report, I don't intend to go through it word for word. I'm sure everybody will be relieved to know. This is the first performance report that we've provided to the current Scrutiny Committee, so really welcome feedback and observations in terms of what committee members would like to see in future and also how they would like information presented. What we've focused on in terms of this report is making sure that we've covered the key areas where we've currently got performance which is below current expectations. We've also done a summary of complaints information received, as well as looking at where we've received compliments as well, to evidence some good practice to give us some balance in terms of that report. So just in terms of performance outputs, I think there's 5 key areas that we were looking at. So the report gives an explanation of each of these areas, but I'll just give you a sort of brief overview in terms of them as we move through. One of our key areas of focus or key areas of concern is around the current waiting list for deprivation of liberty safeguard applications. So to provide some explanation to committee members who aren't aware, deprivation of liberty safeguards are applied where somebody's being restricted from their freedoms. It's a very complicated, long-winded process and very challenging for all local authorities to manage. CQC in their recent round of local assurance inspections highlighted this as one of the key areas that the majority of local authorities were facing difficulties with in terms of keeping up with demand, and we know that previously there have been proposals to change legislation around deprivation of liberty safeguards. So we currently have a waiting list which, as you'll see on the graph on the slide, has come down significantly over the course of a year, but started to peak and then sort of trough sort of more recently in terms of the level. So we're currently sitting just above 1,400 applications that are waiting. These are risk assessed to make sure they're dealt with in a priority order, and they are prioritised on that basis. In terms of the volume, probably what I should highlight is where somebody goes into hospital, hospital will submit a DOLS, sorry to say we keep using deprivation of liberty safeguarding terms, so they'll submit a DOLS application for the period of somebody's stay if they were working on the basis that they wouldn't let that person leave of their own free will. So you can imagine that number of applications being received dramatically inflates that number, and given the fast turnaround in hospital admissions and then discharges, that makes it difficult to keep on top of. We invited colleagues from regional ADAS into the council in January to carry out a peer review of our DOLS service, and that's been really helpful in supporting us to pull together an improvement plan around work that we're doing within this area, but it is very much restricted to how much resource we can put into this work, and like I say, fundamental reforms of the DOLS system taking place to support us in terms of moving that number down to a more manageable level. In terms of, sorry,
Neil?
yes, certainly.
Rosie, do you want to come?
Just delve into each one as we go, because there's only 4 of them, so we don't really want to lose the thread. And I was shocked by that number. I don't know whether other members were, but you know, 1,400, 1,500 people who might be being held against their will. Not necessarily, I understand that, but I mean, for instance, how do we cross-check? We are a scrutiny committee. How many complaints are you getting regarding this deprivation of liberty, and have those gone up? And how are you going to address and change your policies and details to get through those backlog and get it down to a much more manageable level? How many come in per week? How many staff have you got? Is this just a problem that we're building up and building up? Yeah, lots more questions. Thank you.
I think a lot of the questions that you've raised there could apply to many local authorities, like I've just said, in terms of what we're doing to understand how we compare in terms of performance. There is annual benchmarking data that's released, so part of our peer review would have compared us in terms of that benchmarking, both regionally and with councils in a similar position, and we're not an outlier in terms of the volume of applications that we've got. Like I say, it's a fundamental flaw in the system that is needing reform, and we got fairly close to reform 2 years ago through the implementation of what was called liberty protection safeguards, which should have eased up that process, but unfortunately those reforms didn't come to pass, so we're still left with a system that's challenging all of our local authorities. Effectively, in terms of our approach, it's around proportionate decision making. Effectively, we know we've got people in care homes who are being supported, and we receive significant numbers of applications for doles. If we take resource away to manage this waiting list, effectively we're going to take it from the front line, so it's about that proportionate decision making based on risk. Yes, it's not ideal, but without a significant level of investment, because once we get through the waiting list, those applications have to be renewed on an annual basis. We're not necessarily going to be able to keep up. So yeah, there's a number of things that we're doing in response to that.
Yeah, I understand, and please, you don't need to be defensive. I quite understand that you've other councils have got this problem as well. Where are the risks? And what keeps you awake at night? How do you deal with the risk assessment? Which ones are routine and probably the person doesn't even know that they're subject to one of these, because you go into hospital, of course you go into hospital, and then you wait to be discharged and you have a discussion about where you're going to go. So those probably aren't the high risk ones, but the ones that are in care homes who maybe have been discharged from hospital into care home, but they actually definitely don't want to be there. I mean, how do you distinguish between those categories?
Yeah, so we will, all cases that come in will be risk assessed before they go onto the waiting list to understand those circumstances. So like you say, deprivation of liberty can only be applied if somebody doesn't have capacity to make a decision about their care. So effectively, it's not about people who would willingly being denied of their freedom. It's about people who cannot make that choice, but we're making sure that we've gone through the right steps to establish that. So it's through a best interest assessment that then also has to be supported by a mental health doctor, and then it has to be signed off by an authorising body to make sure that the process has been followed appropriately. So like I say, they're risk assessed when they come in, and there's a number of different factors which will look at sort of how risk is applied, and then like I say, that then affects the priority in terms and the order in which we deal with applications.
Can we go on to Councillor Simpson and then Fiona? Then I think we'll move on.
Yeah, thank you. It was actually about the numbers in the report, or understanding them better, if you could clarify a bit. Because in the report it says on 3.4.2, we are holding a higher number of individuals on our waiting list than we ideally would like. So I was going to ask if you could quantify what that means. And then the slide it is showing at the moment is showing up to 1,600 coming down, picking back up again. And it says, what is the target there? Is there a target on there? Or what are we saying is the target on this? And so the last point on it is, what's the sort of longest that somebody could be waiting to be assessed?
So there isn't a target on this slide. So ideally, we like to keep that number below 1,000, recognising that demand outstrips resource. So yeah, in terms of timescales, I'd need to come back to you in terms of understanding sort of what our longest waits are.
Yeah, thank you.
Can you just give a brief description of the people that are in this category? Because deprivation of whatever that term was that you used sounds like they're prisoners, but obviously they're not that category of people. So can you just give us a description of the kind of people that fall into that cohort?
So like I say, it's where somebody hasn't got capacity to make a choice or decision themselves around their care. So that's the fundamental arrangement. Then there will be elements of their care where the doles application will be submitted in relation to that. So it may be, if it was about somebody who there was a risk of them leaving a care home and trying to leave and having to lock doors to stop that from happening and to protect them, then that would give you an example. Or it could be something as not simple, that's not the word, but something in terms of their day-to-day care where maybe for their own protection they had to be strapped into a wheelchair to stop them either falling out, getting out or running for their own safety. So it can cover a number of things, but it's effectively where you're putting an arrangement in place in relation to somebody's care that would stop them immediately doing something that they may choose to do, but recognising that they haven't got the capacity to make that decision.
When you've got this large number of people that you're going to assess, what happens when you've assessed them? Do we have capacity to accommodate those people in different situations once they've been assessed?
So it's not about necessarily accommodating them in different situations. It's effectively saying to the care provider, we agree that the practice you're applying is appropriate and you've got support to do that. So it's fundamentally not changing their care arrangements, but it's making sure that that practice that is being applied is proportionate and appropriate.
Right, I don't want us to get stuck on this one for too long but I wonder, the question I've got about this is, would it be useful to have that information by setting? Is it setting that's important, or is it by the kind of condition that people have that is requiring...
And wait time, and complaints, and how many die before they ever get the assessment done.
Right. So shall we... Adrian, I'm keen that we've got four other groups to cover, so I think we'll then need to come back and say what are our recommendations and action points at the end of this. So
Thank you, Chair. I agree 100% that 1,400 or so people, I would like to see a breakdown of what's a hospital, what's supported living, what's care home, what's in with families. I would like to see a breakdown of the situations they're in, and then we could move forward as to which is are more urgent than others. That would be a better idea for guidance. Thank you.
Yes.
Very quick one, Bob. Can we put this into context? We've got 8 months of figures here. What was happening prior to this? To put it into context, are these figures up, down, middle, mean average?
So the dole service was previously hosted by our colleagues in Northampton, so it disaggregated, I believe, 2.5 years ago. So, and at that point, I think we inherited a significant number of cases, which we then we've sought to reduce. As you can see, sort of the general trend has been downward for a while, but we do get peaks and troughs, which is obviously around those spikes in applications that are being put in.
Okay, thank you.
Right. Okay. Do you want to carry on? Yes.
Sorry, I just wanted to clarify just something. So when we talk about prioritisation, we use the National ADAS tool for prioritisation. It's the one that they've developed by speaking to people that rationalises like who is a priority in terms of doing their DOLS application. But when we talk about doing a DOLS application, please be aware the Care Act assessment is completed. We've done an assessment of what their care and support needs are, and we've put them in a safe setting so that people are safe. The DOLS part of it is just verifying effectively that what we've said in the support plan is right, and that's right to do. But do obviously just bear in mind that people, the purpose of doing this and having this approach is so that we can get people into a safe environment and protect them from harm. And then the DOLS part we can do after, but the priority for us is to get people in a safe setting. Thank you.
The only problem is that you talk about taking people's liberty, and your version of keeping them safe. And we were just sharing stories of I had a mother that our mothers actually trying to discharge themselves in their nightie and slippers and mine was going to get a taxi, yours got on the bus. But these are people, and just because it suits us, because yes, you are safe, doesn't necessarily mean that that's what the person wants, and actually taking away their rights or liberty to choose is really important. Could happen to any of us.
Okay, thank you. Yes.
Yeah, thank you, Chair. As I understand it, to get a DOLS, you need a panel of professionals or a judge to give a DOLS commitment, so it's not like anybody's just sitting there ticking a box and saying you can or you can't do whatever you want to do. But until that happens, people are free to do as they need. Yeah.
And to what extent, can I ask, what's the split between mental health and other conditions?
I'd need to get that broken down. I mean, obviously, mental health, we've got restrictions under the Mental Health Act under sections 2 and 3, but that they wouldn't be subject to a DOLS because they've got their own form of implementation.
Okay.
Right, thank you. Right, do carry on.
No worries. So, yeah, the second area is around our waiting time for therapy, support services. So this is the number of people the percentage of people who've received a visit within 6 weeks of being referred. So I think it has a number that is around 354 people on the waiting list. So it's approximately 39% of those people who are being visited within 6 weeks. The team's working through a number of different approaches in terms of being able to respond. This is obviously our first point around prevention and helping people to stay independent in their own home. So looking at opportunities around running more clinics to get through the backlog quicker, looking at the opportunity around self-assessment with our equipment provider in future, so low-level pieces of equipment can be distributed to people in a more timely manner. But again, in terms of this waiting list, there is a waiting well policy which makes sure that anybody who is on that and waiting to receive a visit from the therapy team is contacted throughout the period that they're on that waiting list to make sure that their condition hasn't changed, that we're getting to them in a timely way, but also signposting them to other support and advice that might be of assistance in the meantime whilst they're waiting for that assessment and that visit.
Right. Do we want to take questions on this while we're here? So I'm trying to understand the figures. So this shows how long people are waiting at any point in time. So what I'm wanting to know is, only 40% are seen within the 6 weeks.
Within 6 weeks, yes.
To the other 60.
So, well, how long? What's the average time for people to be seen overall? I suppose is the question. And what are the outliers? Are there people waiting 3 months and 6 months to be seen? And are some people seen more quick? Who are the people who are sick? Why are some people delayed? And is there any way of, do we have an action? I suppose the question then is, do we have an action plan? I mean, what's the ideal? What would be the ideal? I'd have thought that you'd be wanting to get it down to sort of, if people are needing OT, that means to live their lives, they need help to be adjusted to where they are. Therefore, you'd want to be seen ideally in a couple of weeks. Would that be the kind of ideal? I don't know. We'd need somebody sort of with an OT background to say that, but my guess would be it'd be a couple of weeks.
I mean, this is an issue really for the Integrated Care Board, because some of it will be either stopping people from going into hospital or making a home fit for them to come out of a hospital. So, it's the integration and between the health service and ourselves is really important here.
So is this our teams needing to do these assessments?
So this is our community occupational therapy team. So we will have OT support linked to the discharge pathway to make sure that people are getting that support as they're coming out of hospital. As you rightly say, people need to make sure they've got the right equipment in place to support that discharge. But this is effectively our community occupational therapy team, where people can self-refer themselves for support, or if they think they need equipment, and this is getting out to them in that time scale. Yes, obviously we'd like to be the majority of people being seen within that 6 week period. It is really around resource versus demand pressures, but looking at ways, like I've said, looking at whether there are smaller pieces of equipment that we can allocate that sort of people ask for, rather than carrying out a full-blown assessment, because actually the cost of undertaking an assessment is greater than the cost of the equipment that somebody wants, and making that rational judgment. So it's exploring all of those opportunities and options to speed up that service and make sure people get that support quicker.
And do we as an authority have an action plan to deal with this at the moment?
So we'll have plans in response to the fact. Sorry, we'll have plans in response to the fact that metric is underperforming. So that'll be those things that I've outlined about areas that we're exploring and things that we want to implement to improve that response time.
Are there links with the lapse? And where do your referrals come from? You say self-referral, but presumably a lot of them may come from social workers, health visitors, GPs and so on. And where's the relationship with the lapse? And I gather the lapse, we've got the pilot scheme going on, and the lapse are going to be given a budget, I understand. So again, is there any way that the relationship with the lapse can speed this process up?
Yeah, I mean, you're quite right. The majority of referrals, people can self-refer, but there will be a lot of onward referral from other professionals, social workers, people who've seen the person in question face-to-face. I think the point about lapse and how we look at aligning this service to local area partnership delivery and making it accessible that way is definitely something we should explore. Yeah, completely agree. But yeah, that's something that we'd need to take forward.
Right. Yes.
Do we have any much say as a local authority in the waiting well? Because a lot of people are probably slipping through the system a bit. And the waiting well, why is the waiting well, or supposed to be waiting well?
So the waiting well is a local policy. It's been designed using regional best practice, but how we apply it and how we use it is entirely up to us. So yeah, we've got a local understanding of how that's being implemented and making sure that people are getting those regular checks and that we're keeping up to date in terms of their position and making sure that they're getting support during that time as well.
Thank you. Councillor Baker.
Those of us who've had people in hospital know very well that the hospitals do infer that the reason that people are still in hospital is because that social care haven't sorted out their requirements. I know that because I've been told it many times when I've been there. So is any sort of priority given to people who are in hospital? Because obviously the big thing is to get them out of the hospital to relieve the beds for other people that need them. And I do know that people end up being in hospital a long time waiting. I'm kind of always been a defender of the council when I've been there, obviously, to say, well, there's other reasons why. It's not just that we haven't done it, but is that an issue still?
Yeah, like I say, we've got an OT attached to our reablement service to make sure that we've got that joined up support and we're looking holistically at people's needs as they're discharged. This is purely around our community team. So, yeah, so the hospital is dealt with separately, recognising that demand and that need for that quick response.
Right, shall we move on to the next and then...
Oh, sorry, I skipped one that wasn't... Sorry, I skipped one that wasn't on purpose at all. So this is around support for carers. So what I should say with these two measures is they're annual measures. So they're not on a monthly basis. It's taken off the percent of carers who find it easy to find information and support is an annual measure off a survey. The others who are receiving a direct payment is a measure that we track. Ashley might want to jump in here in terms of our carers offer, and I don't want to sort of steal into it, but I think what we probably say is around that direct payment measure that we've done a lot of consultation and co-production in terms of what carers want on the back of that direct payment figure being quite low, and actually the co-produced offer for carers responds to that. Ashley, do you want to take over here?
Yeah, so some members will be aware that we developed our carer strategy in 2024. That was fully co-produced with carers of people who have support needs, and We did a lot of surveys for carers and looked at national data. And through that co-production group, we pulled together about 17 different priorities that carers told us that they wanted us to focus on. So one of them was around direct payments. So prior to the launch of the strategy, we outsourced the management of the direct payments to our carer support provider, which is Northamptonshire Carers Trust. And their approach that they did was, what it didn't do was factor in the wider support offer that was going in for a cared for person, for example. So if somebody was receiving respite care for 4 weeks a year, that wasn't factored in when the Carers Trust were assessing whether somebody needs a direct payment. So what we did is we changed that approach, because what we wanted to do was to make sure that carers' direct payments were looked at in line with what a cared for person's needs and support that they're getting are. And as a result of that, we brought those carers assessments back in-house, and that went live 1st of April of this year. So we processed quite a few carers direct payments, but what we found is because we invested more money this year into the carer support offer to develop the services that they offer as part of that universal offer, from the 1st of April, we've actually found that the requests coming in for direct payments have actually reduced, and that's because unpaid carers are more happy and accessing more of the support being offered by the Carers Trust. So whilst that it looks like it's going down, and according to a national metric, that would look like we're behind. But the reality is we've given the carers, the unpaid carers, what they want, and that this is a consequence of that. So we will follow up with more surveys with carers to make sure that this is what's happening and this is what they want, and that they are getting the support. So we do that relatively regularly, and we feed back and we react to that. But at this point in time, the number of applications or requests for direct payments coming in is massively reduced as a result of that carer support offer being enhanced.
I remember, obviously, we were changing our provider, but one of the main criticisms with that provider is that they didn't really have they were chugging along with the people that they knew, and they weren't actually proactively seeking out people who were in the caring role. And I wondered whether that has now changed, whether you're able and have the capacity to do any better. And are you using, for instance, the LAPS? Because it seems to me that there's a lot more, and I experienced it myself. I was a carer, but I didn't even know about all of this stuff. And it often is particularly Northampton-centric, I have to say as well.
Yeah, happy to answer that question. So we still have the same carer support provider. The difference now is that West Northants have commissioned it on its own when it used to be a county-wide offer. So we have an individual contract, and we've set up a new specification within that. So in terms of the LAP offer, part of that contract and the specifications and what carers told us they wanted was one-stop shops. So we have one-stop shops in all of the local area partnerships, and that's advertised quite a lot, and we do have unpaid carers coming in who can access support in their localities rather than it being very Northampton-centric. So we did address that. That's what carers told us that they wanted. And then in terms of identifying more carers, we did do a piece of work in 2020, started in September 2024, and we used some national funding called the Accelerated Reform Fund, and that our whole objective about that was finding more carers, because what we did know, according to the census, that there was about 30,000 carers in West Northamptonshire. The carers that we knew about was about 10,000. Since we did that project, the number of carers that we know about is about 13,000. So we managed to find another 3,000 carers through that part of it. And we continue to do it, and it's part of the specification with Northamptonshire Carers Trust that they do continue that work to identify more unpaid carers. So it has gone up by a significant proportion in terms of what we know about and who are accessing support.
It'd be really interesting if that gets reported annually to us, hopefully to see it keep going up as more effort is made to reach those 23,000 that aren't on the list.
Yeah, thank you, Chair. I was trying to understand from in here what does good look like? Because I think you were saying with the direct payments, it seemed to be that it actually was showing some success that it had come down. Yeah. But even though that's the case, what should we be aspiring to, and how does it benchmark with others? And similarly on the second metric as well. Obviously that seems quite good, but what are we aiming for, and what should it be, do we think?
It's a really good question. So it's the first part of it is difficult to answer, because if you look at national benchmarking, everything indicates that we're underperforming because we offer less carers direct payments. It misses that entire narrative about what unpaid carers have actually said that they want. And one of the questions that I think we've added this year into the carer survey, because we're allowed to, in the National Carer Survey, we're allowed to add a couple of questions in there. One of them is, are they happy with the support that they're receiving? So if the question is that they're not getting a direct payment, but they're happy with the support that they're getting, then I don't think that one's really relevant, in all honesty. But I think we just need that survey to be done. So the survey's recently gone out. We will probably have the results back from that about February time. So if it was the request of the Scrutiny Committee that they wanted us to come back once we got that survey back and answer that question, I would be in a much better place to answer it than now.
Yeah, I think that would be good to you, Chair, to see that, because it gives us the whole picture then, doesn't it? And
yeah, and then our final area sort of where we've got a focus on is in terms of making safeguarding personal. So again, apologies if I'm explaining things to people that they already know. Making safeguarding personal is effectively outlined within the Care Act. What it does is, rather than people going through a safeguarding inquiry and that being a standard approach of steps which is driven by the local authority, what it asks is people to define the outcomes they want to see from that safeguarding inquiry, what it is they're looking for support with and help with. These two measures are more around the recording of those outcomes than they are necessarily against the delivery of those. So for some time, obviously it's of key importance that our frontline staff are recording where outcomes have been asked for or we understand where they've not been asked for, and making sure that we're taking steps to address that. So this is particularly about our focus in that area of work of data capture. So as you'll see, the report says that they were both areas of concern. Actually, when I came to put the presentation together yesterday, I noticed the one where we were reporting issues about outcomes not being asked for had actually improved and dropped significantly since I wrote the report. So not sure if teams got tipped off that the report had been written, but yeah, so they're both fairly low, but it's about recognising actually this is really important information for us to gather and to be able to respond to. As I've said in the actual report that committee members have got, this appears to be a data recording issue, because actually when those cases where we haven't necessarily recorded whether desired outcomes were asked for or not, you can actually see in the narrative that's recorded in the case that there was a conversation that took place, but we need to reflect that because we want to make sure that it's appropriate and it's right. So it's picked up through our monthly. You're all right, no worries. So it's picked up through our monthly performance conversations, and it's picked up in one-to-ones with relevant staff if we're noticing that there's a data recording issue. And like I say, we're driving it that way. It doesn't appear to be a practice problem. It's more of a recording challenge.
Thank you. Okay, do you want to carry on?
Yep. So just moving on to case audits, there's some narrative in the report just around our case audits approach. Clearly, it's not performance isn't just around top line metrics, around sort of numbers that are delivered. We've got a strong case audit policy and process that we go through on a monthly basis with staff to make sure that the quality of advice that they're giving is appropriate and identifying any issues or areas for improvement. So as you'll see, the headlines from Q2 were sort of really strong performance around legal compliance and involving the person who we were supporting in terms of planning and designing their care, and obviously the timely completion of assessments. However, there was some issues around feedback collection, which is something that we've asked all teams to do so we can get an understanding of people's experience of the assessment process. So that's more something that we've chosen where staff were considering the use of advocacy support services and then making sure that people were getting documents shared with them on time. So those issues would have been picked up with the individual workers where they were identified, and plans would have been put in place to make sure that they were responded to.
Yeah. Just a brief question. How many cases get audited as a percentage of the total cases?
Yeah, that's a good question, and apologies, I don't have a figure for you, but I can get that for you. Yeah.
Yeah, thank you, Chair. I'm curious about your advocacy consideration. Are they internal advocates, or you're about specialist advocates like financial advocates or something like that?
So all of our staff have access to an externally commissioned advocacy service. So we've run a procurement for that recently, probably in the last... Oh, it's just been, so we're in the process, sorry, I knew it'd been to Cabinet. So we're in the process of running that procurement at the minute. At the moment, it's an independent advocate called Power, who's a national provider, but it's making sure that we've got that separation between clearly our staff and the advocacy support that people can access.
Okay. Right, shall we move on?
Yeah.
Complaints.
So complaints, as we can see, the number in the graph is sort of slightly out because that was taken as a screenshot from our Power BI system yesterday. So it was 140 complaints when the report was written. That's slightly gone up during the course of the last couple of weeks. But we are pretty much on par in terms of where we were this time last year in terms of volume of complaints that we've received. The majority are around assessment and care planning and financial issues. So in terms of assessment and care planning, that will be about particular choices around provider or accessibility of provider and that planning process. Financial issues, as you can imagine, would be around charges that are being applied and the assessment process for those charges. That tends to be a pretty common theme, I think, for the last Scrutiny Committee when we did an update on complaints. That was in exactly the same spot. What I should probably say, just to give committee members a level of assurance, is that complaints as a theme are discussed on a monthly basis with our senior management team, so we understand the themes, the learning that's coming out of those, and then if there's any need to change policy, process or approach, that will be then picked up so we can make sure that we're taking that good rich understanding and learning from the complaints that have been submitted.
Thank you, Chair. Through you, I'm just not quite sure on the figures there. 140 complaints as of the end of October. Is that for the month or for the 12-month period or 6 months? Or
that's for the year to date.
For year to date. Oh, thank you.
Yeah, so relating to that again, it's actually my previous question really is to understand the percentage of people who are complaining of the number of people who are going through the system. Because obviously, if it's the same as last year, but you've got a lot more higher numbers of people going through the system, then the percentage of complaints is coming down. So I just wondered if that's possible.
Yeah, we can get those numbers, but yeah, absolutely take your point. I mean, in comparison to the number of interactions and cases that we see, 160 is obviously a relatively small number, but yeah, more than happy to get the detail on that.
Thank you. Obviously, a lot of complaints actually will cross over various of these categories, won't they? And how do you allocate? Are they allocate if it's communication and assessment and delay? Do they appear in all three, or do you just give a lead one?
My understanding is it goes to a lead one, the primary purpose of the complaint.
And out of these complaints, how many go to the Ombudsman and how many have been agreed in the complainant's favour and against us, or vice versa?
I think roughly on average, it's about, we've had 7 complaints this year, I believe, that have gone to the Ombudsman. And when I say gone to the Ombudsman, there is a distinction between people approaching the Ombudsman and then the Ombudsman choosing to turn that into an investigation. Obviously, everybody's got the ability to do that, but not all complaints to the Ombudsman turn into an investigation. So I think our number for the year so far is 7, just from a conversation I had this afternoon. I would just need to double check that. In terms of those numbers that are upheld, again, that's a figure I could get and provide for committee.
Assessment and care planning, which is probably open to interpretation and people's wishes and desires. The largest number that you've got here is financial issues. Is that, do you think, showing a shortfall in people's ability to manage those financial issues? Do we need more input from ourselves into the handling of people's finances along the line?
I'll hand over to Ashley because financial assessment sits within his area.
No is the answer. The vast majority of those complaints are people who are unhappy that they have to pay towards their social care card charges, and or there's been a delay in telling them that they have to pay towards there. So care might have started and they don't get told that they're charged for, say, 2 months or something like that. Those ones, those are primarily what the complaints are about. And in response to the 7 LGOs, that number's also reflected into the LGO complaints as well, because the majority are about properties being taken into account in the financial assessment, people having to pay, and delays or administration errors in processing a financial assessment. Those are the key areas.
Sort of brings me back to the beginning of the conversation, that perhaps we need to do more to actually inform the world that that will actually happen. I mean, we all know that will happen. If we go into care, your house goes, doesn't it? But if there's a delay in that, that might be a shock if they didn't know in the first place. So maybe that is, the onus should be on us to make sure everybody knows that. Your next social media campaign.
So just to respond to that, so there's a couple of things we're working on. So we've just refreshed what we call our Paying for Care leaflets, with the paper leaflets. The website's being updated with more up-to-date information. At the same time, we're developing, and we're very close to developing what we're calling our self-funder strategy. So it's people who have money above 23,250, and then the government will class them as being self-funder and able to afford to pay for their own care fees. But we're doing some work around reaching out to people who are self-funding early about things like managing their money so their money lasts longer, but also making them prepared for what happens when their money falls below that threshold as well. So it's in development at the moment. We've got to go through sign-off and things like that, but at some point in the future, I'm quite happy to bring that back to scrutiny if you would like to see that.
Through you, Chair, thank you. You know, we're looking at this 140 complaints for the last 12 months, and it's been 2.5 years roughly since we took this in-house. Some of the suggestions that we can do from this scrutiny committee is look at policy changes or methods of working. But we need a clear structure of what we're doing. So 140 in the last 12 months doesn't really tell us how we're faring, to see what we could look at changing or improving, or are we doing okay? So I think a little bit more information as to how we got where we are would help, if that's okay.
Not for the last 12 months, is it? It's from April to October, to be clear. Yes. Yeah, I thought so. Yeah.
But I suppose in response to your point, that a deeper dive into complaints, what's happened in terms of policy changes on the back of complaints, what the responses have been, that's the sort of thing that you'd want to understand, just in terms of making sure that when we say that we're acting on feedback, that you can see that visibly. Yeah. We can do that.
What am I doing? So there's something about across sectors, really. I need to understand which sectors those are. And I think, do we have a benchmark for complaints? Do we have a target? Are we trying to, do we have a benchmark for other authorities? Who are the best performing authorities, and what can we do to get down to a point where kind of complaints of, this is about 200 odd a year, something in that sort of region. That seems to me, my naivety, a significant number of people who are unhappy with our service. Is there a way that we can get to a point where, and it might be there are some areas like the financial area where there will always be a proportion of people who will be unhappy, because that is how it's set up, and there will be people who will vehemently object, and they will follow that through by making a complaint, almost as a sort of political statement. But I think we need to understand where it is that our practice needs to improve, and where it is just a product of the system that we've got. Am I waffling?
Once again,
Come on, that's it.
putting it into context, unless I misunderstood you, the last time we received information, or the beginning of it, was 2.5 years ago. This is for 8 months. What happened to the rest of the two years, or just under 2 years, figures? Is there any improvement? Have we been able to modify? What is our plan for the future to ensure that we can modify all matters at every level?
Sorry, apologies. The 2.5 years figure,
Isn't that when?
2.5 years was when that was the.
When it was formed.
There was the disaggregation happened 2.5 years on the dole service. This is around adult social care in general.
It's a different system.
But
surely we need, it's not a graph for 8 months. It's a graph over the longer period to make sure that we improve. Or have I completely...
Well, I think that's also right, but I think it all... Actually, the total number obscures a lot of detail, and it's almost the detail that's important. It's the categories that are important, I would suggest.
Yes, Chair.
So I think it would be really good to have, yes, we need it over comparable time periods, but also we need it in the detail, and we need a sense of the action plan to tackle the key problem areas, or a narrative around those key problem areas, so that we really understand, the financial issues. Because I think I'm involved. I'm one of those complaints. Not me personally, but one of my residents is one of those. So I kind of understand what some of the issues that are going on. Andrew.
Sorry, it's back to my point previously, really, that I think Neil said it was the same volume for the same period last year. So if that's the case, but the number of cases has gone up, then the number of complaints as a percentage of the cases has come down. And so I think we just need to know that, and that shows us that we're going in the right direction, doesn't it?
Yeah, so good, Chair.
Yes.
through you, yes, you're right. So the sectors, you know, is it people waiting to come out of hospital? The complaints are coming from care homes. Are these complaints are coming from supported living facilities? Where's the balance? Is there a balance? Is it through? Is it, you know, in what area? And where do we need to put more work in?
Right. So have we got through are there any other areas you need to present to us?
There was nothing on this report.
Right.
The final section is around some positive stories and positive examples, which there's a narrative in there which speak for themselves.
Thank you.
People can read through.
Right.
We shouldn't forget those positive stories. I think it's really good to see those in there because we've been here asking questions. And it might sound a bit negative some of the times we're asking questions. Some really good positive cases in there, which brings it to life, doesn't it?
Yes, Chair, we have.
Good.
Would you like me to summarise anything, or?
I'm not sure it's actually useful to go through all of it again, but I think if we're confident that you've got those, then that will be really important. And I think we then need to kind of pick those up. Well, it's for the team to pick those up and work out how we then, when would be the next most useful time to come back to committee with some of the answers.
Yeah, thanks, Chair. I think it's important that we do get some of these resolved, because at the end of the day, these numbers, while numbers are great, there are actually people at the end of those numbers and families that you know rely on this. So I think it's important that you know we're seen to be taking care of these. Thank you.
The complaints number, could we have a look at that alongside how many people we're actually dealing with? Because, for example, 140 out of 5,000 is not that bad. But on its own, it looks a bit... 10%.
Okay, yes. Right. Well, I think that's the end of that presentation. So thank you for that, Neil. That was a bit of solid piece of work I think we've got through there, and hopefully that will inform us next time we bring a report. And I think possibly that you'd be bringing these sorts of reports about twice a year to this committee.
Yeah, absolutely. I mean, as and when the committee sort of wishes, really, I guess I'd sort of go back to that opening point that I made. If there's anything that committee would like to see that they haven't, I mean, it's been a really useful conversation in terms of understanding the level of detail for future reports and getting a sense of that, which we can make sure that we include, and we did a deep dives in the areas that we're looking at. But yeah, welcome any feedback about areas or updates or how you'd like to see that information in future.
Right. Thank you very much. Right, shall we move on? So we spent 45 minutes on our half-hour item there. So we'll move on to the workforce planning report. Is this you again?
It is me again, and apology, I don't have any slides in terms of this one, so I'll just try and capture the highlights of the report. So we're obviously asked to provide a report to committee in terms of adult social care's approach to workforce planning, and focus on where workforce development and recruitment were required. So just in summary, the report starts with an introduction about why workforce planning matters, which is really about ensuring that we've got the right people with the right skills in the right roles at the right time, making sure that we're responding to challenges that we're seeing in terms of the day-to-day delivery and the skills required for the roles that we've got across the director, and then also making sure that we're able to deliver continuity of service, high quality care, and maintain financial sustainability and compliance with our statutory duties. So in terms of workforce development activity, we've clearly got focus on internal learning and development. So we've implemented new policy, new training matrix, and that's linked to our e-learning platform. We make sure that staff are getting protected development time, and have also got access to Community Care Inform, which is a repository of information and training aids that they can use during that development time as well. And through practice audits, we're also finding areas where we focus on in terms of a topic of the month, or our principal social worker undertakes a 7-minute briefing around areas that have been identified where we need to strengthen practice and to promote a learning culture. We also provide externally commissioned training around statutory knowledge that's required, and we do this through, we also do collaborative sessions with partners as well. And we've got arrangements in place around peer support, and also making sure that we support newly qualified social workers in their approved year of social work experience. So that's making sure that when people are becoming social workers for the first time, that they're given the time and space to develop and learn and practice appropriately. Clearly, our other key area of challenge is around recruitment activities. So we know there's high turnover, and in terms of some of our in-house care provision, we've got competition with the NHS and private providers. So we've undertaken a number of initiatives to respond to that around digital work. Right-to-work checks to make sure that we're improving compliance and efficiency, targeted advertising campaigns or keeping rolling adverts in place so we can make sure that we've got people recruited quickly, multi-channel campaigns where in terms of advertising our job roles so we're getting the most reach possible, and also streamlining our recruitment processes, which has received positive feedback from applicants and candidates. In terms of our achievements, 18 social workers were recruited in 2024, and we recruited another 19 by the end of October this year. Some of our key risks are clearly around recruitment and retention, and pressure remaining high in that area. We know that there are visa changes which are impacting on caring roles, which we've done, well, I say we, Ashley's done a lot of work around and has reported back to Scrutiny previously on our work around the international sponsorship scheme, and also the capacity challenges of supporting our newly qualified social workers. So we recognise that it's really hard to attract social workers, and they're in sort of really high demand. Growing our own is an approach that we've been taken, but that does come with internal pressures in terms of making sure we've got the right support on site available. In terms of our next steps, we're launching a learning development policy and training matrix, and continue to salary benchmark and undertake recruitment improvements, and also monitor the capacity we're getting through the ASYE programme and support structures.
Thank you very much. Councillor Herring.
Guess who? I have to say that as a paper for Scrutiny, I find this almost meaningless without having an establishment. You're a huge directorate with lots of aspects under that directorate, and we need to see the establishment, where the gaps are, where the vacancies are. I mean, the vacancies could be spread nice and evenly across all the directorate, or they could be in one particular area where you can't recruit them for love nor money. And as a piece of scrutiny, I'm looking at staffing. I think that's got to be where we start. Thank you.
So in terms of where we've got our main vacancies, I think, like I've mentioned, social workers is a key challenge. We know it's a challenge as a profession. The other key area for us is around our in-house care delivery services. And I think, there's clearly pressures on the whole sector there, but yeah, apologies that you didn't get the level of detail from the report.
Yeah, I think we need numbers, and to know exactly how many we're short, which direction is it going in, and then we could decide as a committee whether we wanted to look at a particular area and look at the challenges that you've got and so on. We're coming up to the budget review. I don't know what the implication of that's going on. We already can see that you're short of occupational therapists and people to do the deprivation of liberty work. So yeah, it's knowing where the pressure points are and where you're willing to accept that pressure and where we as councillors are not.
Yes, I'd be also interested in where we're using agency staff as well, because I see that I think is it the northeast of England. They've managed by all the local authorities in an area working together. They've reduced their agency staff to more or less zero, and they've got a full complement of social workers as well. So and that's got to be our target, that we have a proper establishment, that we reduce our agency staff to zero, and that we have a pipeline for training social workers by various routes, so that we have a full establishment. And that is I'm sure is quite a challenge, but that is, I think, where we need to get to. And I think there's no reason why, as an authority, we couldn't be doing that, really. It involves good links with all the social work courses. It involves, I think it also involves actually creating that pipeline of people who want to be social workers. So it's how do you get people who have the personal attributes that with training can enable them, and for us to really say that these people are important to us and valuable to us, and also, you know, I presume that we've also got to think of the recruitment needs of the Children's Trust, because there are some people who would social workers prefer to work in children's, and there are other people who prefer to work in the adults area. How do we get that balance right on the social work courses so that actually they're delivering to us the kind of social workers that we need? I'm waffled. Alison.
You're not waffling, you're guiding us. Yeah. You've actually almost touched on it too. The thing that worried me about this report is that how do we monitor the people we take on board? It's a new area to me, so forgive me, I'm ignorant. How do we monitor the area? How do we understand and comprehend the skills of the people that we're employing? And when you say that we had 18 and employed another 19, how many more did we lose? And what are the projected figures for the months to come? Because we understand completely that you want to improve the calibre and the quality of what you're providing, but at this particular moment we don't have a backlog of figures to tell us what's happened in the past and what you hope to aspire to in the future. Thank you. Jem.
I think social work is a very torturous job to be in. So we do have to accept that lots of people come into it and burn out quite quickly. And there's always a churn and churn. Yes, there is. 6 years in the Children's Trust has told me that's true. There is a big turnover in social workers. So I think it would be good to perhaps look at this council you're discussing that's got to the stage of having no agency workers, because, for example, I know this winter you're going to have to take on agency workers because people will be off with flu, with this, and lots of work to be done. So it is a bit of a torturous route, and a really good performing council will have good quality social workers on board. We need to get our council to that level, I think. But it could be helpful.
I'm going to challenge this area of this issue of burnout. I think we've got, if we are training staff, and we're investing in training, then we've got to find a way of looking after them so that they're supported. And it might mean that, you know, if there are high attrition roles, that people have to be rotated in and out of those roles. And that's but it seems to me that we've got to look after our staff. They're valuable commodities, expensive to train people, and we want people to stay, because it's the experienced social workers who are the more experienced a cadre of social workers we have, the more experience. And it is we are in a people industry, really, and it's the people skills that we need. It's not just a systems thing, it's people and systems together. And it's how do we, do we as a department have an action plan relating to, what are the roles, what are the levels, how are we training them, what are the attrition rates and how do we do all of that, and what is our plan to make sure that we get to a point where we've got a stable state. I mean, there will always be people being promoted and going on to more senior roles, and that's what we want to see. There should be career progression, but I would really not want us not to be losing people out of the profession. That would be my objective. So I think, Adrian, do you want to come in, and then Ashley, who can respond to my...
Thank you. Thank you, Chair. Yeah, you're absolutely right. You're right on how we need to develop, and Councillor Herring's absolutely 100% right. We need that schedule. We need to know what the figures are. In all, across the departments, across the type of staff that we need, and how we train and recruit and train and keep them with what we can do. I'm sure Ashley's going to sort that out any second.
Do you want to come in, Hayley, first, and then we'll go to Ashley, and he can answer everything.
Thank you, Chair. You mentioned about what you was hearing about in the northeast of England, about local authorities up there that had almost zero turnover of social workers and staff. Could we not look to possibly, I say this very candid, more successful local authorities? I know it's a huge issue, retaining staff, and I know it's a great responsibility on social workers. I had a case, a confidential case as councillor today, and I had a good report, and I felt yes, and I felt almost like I'm not a social worker, but what happened, I felt, I can understand how teachers and social workers, because it was like, woo. I was excited for the family. So could we not, benchmark and look at more successful local authorities than we currently are? Because there must be a way, because at the end of the day, we know that the outcomes of people in care and the adults in care are going to improve if they have that positive, consistent relationship with the same people, rather than having agency and whatnot. But the second sort of point to that was, do we have a bank of social workers, almost like hospitals have banks of nurses? I'm thinking the schools, they have some successful schools have almost the same supply teachers. Could we not have that as well?
Okay, Ashley, do you want to come in and give us the...
Yeah, I'll just share my
wisdom, yes.
My wicked thoughts.
Yes.
Yeah, sure. So just a couple of parts. So when we obviously every year we ask our existing workforce who are not qualified social workers to come forward and say to us, do you want to be a social worker? And if they do, then we take them through that intensive training program, because as you all know, you need to have a degree to be a qualified social worker. It's intensive training. It's a lot of support for staff to give. So we have a finite number that we can manage within our existing resources before the business starts to become unsustainable. Yeah. In fact, that our review numbers and our Care Act assessment waiting lists will get out of control. So we have to balance that finely. But one of the things I think that is a challenge for us, and I think Neil was far too elegant and polite to say this, but every bordering local authority pays more for social workers than West Northants do. So I'll just put it out there, but every authority that neighbours us pays more for a social worker, which puts us at a bit of a disadvantage, even as a starting point. Thank you.
Right, well, yes, Adrian.
Yeah, sorry, Chair. Again, be the one to ask for numbers. How much more do you believe that they pay? Because obviously it has to be a huge amount to make a difference to travel to the next county from, if you live here, sell your house, move, or whatever.
Warwickshire. No, it's over the border. It's not that far.
Yeah, but your work will be all over the county, won't it? It won't just be at the border where you can get houses. Yeah, well, you'd have to be like, our areas all over West Northants.
Do you want to respond to that, Ashley?
Yeah, I think, this is from memory, Councillor Cartwright, so I'm not entirely accurate, but you can go to North Northants Council and I think it starts 7,000 a year more than it starts in West Northants.
Right, so as a scrutiny committee, I wonder if this is an issue that we really ought to be thinking about making a recommendation to we don't see the sort of, we haven't got the information about salaries and gradings and so on, but it seems to me from what you're saying that is a significant issue. And how that goes through the local authority in terms of who makes the decisions, but I'd have thought we want a well qualified, and we need to retain our social workers, and I think salary is an important part in doing that. Andrew, come in.
Yeah, thank you, Chair. I mean, I think whether we make a recommendation or not, we've got the portfolio holder here, Cabinet Member responsible, so I would wonder, hopefully she's obviously been listening to what we've been saying and perhaps can give her view of how she's could take this forward.
I was just going to say, well, this falls beautifully into the fairer funding work that's going on at the moment, because we're one of the lowest funded councils in the country. North Northants get more money than we do, so they can pay more money. So if we're going to pay that salary, we're going to have to take money out of other budgets that we've got. So the fairer funding work is important that we do.
If I could come in here, I have definitely been paying attention and making scribbling notes, which I'll compare with Richard's, because he might have a few more than I do. There are a lot of points that I really want to take forward and look into, and obviously the pay. I've been aware of the low pay for carers and social workers for some time, and I think everyone knows that if you pay a poor salary, you're not really going to retain the staff. So I definitely want to see if this is something we can address and hopefully change, but we need to see what the budget's doing, and I need to just speak to a few people. Is that okay?
Right. So, Councillor Atkins, do you want to come in again?
I was just going to say, obviously, we want the best social workers.
Yeah.
What is the best? No, I'm joking. But we do, seriously, we do. Is there not other ways? Obviously, salaries are very important for everybody, but is there not other ways we can incentivise our social workers here in West Northants?
So I wonder whether this is, we've got the fairer funding settlement coming. I wonder whether we need to bring this back to this committee, perhaps with a kind of a paper setting out these issues about, and I think there are two issues. One is the recruitment issue at one end in the pipeline and making that work, but the second is the retention issue. And I think it would be really useful to have a paper perhaps in the new year to look at this as, and it seems to me is part of the budgeting process. It's probably not going to get anywhere for this coming year, but if we're looking at the year after, then maybe we've got to be thinking in those terms. But it seems to me this is quite a significant issue. I've got other views which I can share at another time, but I think, is that sufficient a discussion on this item for the moment, and perhaps bring this back in the new year when we know the safe, and we can have some a kind of a matrix of roles and staffing levels, and just sit so that we understand that and can make recommendations perhaps as a way forward. Yes, Richard is going to summarise where we are, which will be really helpful.
Thank you, Chair. So, obviously, in the discussion around this paper, the committee's identified a number of points, numbers of our establishment, First and foremost, the use of agency staff, numbers of agency staff and cost, recruitment and turnover, how we look after our staff, benchmark examples of best practice at other authorities, and obviously how we would intend to target zero use of agency staff and develop the council's own pipeline of qualified social workers. So following on from your suggestion, Chair, to maybe bring this back, we have a meeting on the 20th of January, by which time the fairer funding settlement details will be known, the local government settlement will be known, and it's something you could also involve the Director of Human Resources in with regards to pay and grading, because the council's obviously gone through that project in the last 4 years or so as well. So I'd put that back to you, Chair, as a sort of an action plan for this item to go forward.
Thank you. Yes. So thank you. Any further comments, Neil and Ashley? Are you happy with that summary? Do you want?
No, that summary is absolutely fine. Happy to bring back a report in the new year. Just on, I think, your point around bank staff, Councillor Atkins. Bank staff is something that we've looked at in terms of our in-house care homes and creating our own bank in that area. Whether it's doable, I think, in terms of social workers, I'm not sure. There's a whole continuing professional development and practice issue. I think that may be a challenge, but certainly an idea that we'll pick up.
Well, thank you very much. Thank you, Neil, for bringing that paper, and thank you, everyone, for contributing to that discussion, because it is a key area for us, I think. David, thank you for your patience in waiting. I think the idea was that I think my concern has been that we talk a lot about prevention as an authority. I think probably we all have a different idea about what prevention is, and it would be really useful to be given a framework to understand it, so that we're all using the same language and we understand what we mean, and we just have a kind of a broader but also a deeper understanding of what prevention is. And we're pretty confident that you all have the answers to this, so fire away.
Okay, setting out big there. I think based on that remit, you know, and Richard might not forgive me for this one, but my job probably is to leave you with more questions by the end of my presentation than you start with, so that you get an insight into some of the work that we're doing and some of the work that's going on, so that you can know where to ask the questions in the future and who to invite here to have future conversations about different aspects of prevention, about the NHS, about public health services that we offer. And I thought I'd just start with some very broad, to set the scene in the context of where that prevention agenda comes from in a public health perspective, and how people like me think about health and well-being, because sometimes we are a bit strange and think a bit differently. But I just wanted to highlight, often we talk about the role genetics plays, and that is an important aspect of what drives health and well-being. But there are some really other important factors, things like social and economic factors that really drive our ability to live healthy lives. The environment around us in which we live, work, learn and play. And linked very closely to that environment actually is the behaviours that we show. And those two, whilst it may be 5% on the environment and 40% of behaviour there, you could move those around a bit, because actually you can't have good, healthy behaviours without the right environment, and vice versa sometimes. And the bit I suppose that I want to make here as well is that while healthcare is incredibly important to so many people at different times of their lives, in terms of when they are in ill health and seeking health, in terms of good health in general, actually is a small proportion of what influences our health and well-being. All those other factors that I've mentioned before drive our health and well-being much more than healthcare. Healthcare is there when we're ill, when we're sick, and supports us in those phases, but actually there's a large proportion of our lives where we're trying to build the foundations for good health, and that's where the council comes into play. And that this diagram delves into a little bit of extra detail on some of that. At the top there, you've got those things that are closest to health as we know it, in terms of the things that you might turn up to your GP about, your high blood pressure, cholesterol, anxiety, depression, mental health issues. Now, the bit that we get into then is what causes those things in terms of some of those behavioural factors, some of the high levels of smoking in certain sectors of the population, poor diet, high levels of obesity. We've got over 60% of our population who are overweight or obese in West Northamptonshire. Thinking about substance use, thinking about alcohol and drugs and how those influence some of those core health factors. Now, us in public health, we like to keep going backwards and keep going further and further upstream. And the causes of the causes is an area where we're also focused, particularly as part of the idea that whilst public health is prevention, the council's role around prevention is much broader and much about how it can use all the levers at its disposal to influence the health and well-being of the population. And that can come down to some of those things on the left, which are some of the things that people experience, such as social support and isolation, but also the driving factors on the right. How do we, over time, and it is a long-term project, how do we shift some of these factors? How do we support people who experience poverty? How do we ensure that we have good educational attainment and we have children who are ready for school, and therefore that sets them up for the rest of their life? All of those factors contribute to health and well-being in their own ways, sometimes directly, sometimes indirectly. And so my job is quite difficult because what we're trying to do is influence all of those and trying to, in some areas, do it quite directly in terms of commissioning services such as smoking, physical activity, but in other areas, influencing policy and the way that we approach issues, whether it be things like planning or things like how we use leisure parks, open spaces. How do we use those assets to support our population to be healthy? Often those things, particularly in the red blocks, can be described as the building blocks of health. It's a really nice analogy that sort of talks about how actually we need those foundations on which we can build health. And if some of those are missing, as they are in some communities, then actually it's much harder to live a healthy life than if they're sort of fully intact. Now I'm going to focus the rest of the presentations on more of a focus on the adult social care and adult prevention aspect and the work that we do together on that. And earlier this year, there was a adults prevention strategy. It was about 6 months before I arrived. I think it was March time. I've arrived recently in September as Director of Public Health. But it sets a really good foundation for how we think about prevention alongside colleagues in adult social care and tackle it as a wicked problem in the sense that it needs people from lots of different parts of the council to come together to try and resolve it. And in that, there is that definition of what do we mean by prevention so that we all have that common language. And that bit at the top there is what's in the strategy as our goal and our vision through the prevention work to make sure that we're providing the right support at the right time, being proactive about how we work with individuals and focusing on their strengths and the strengths of the communities they live in to help create good health. We often talk about prevention in 3 tiers. We talk about primary prevention, so trying to prevent disease or injury before it ever occurs. Secondary prevention, so where people might have the first signs of illness or ill health, such as developing high blood pressure, and how do we support those individuals then to take action so that it doesn't worsen and develop into something that requires further support. And then that tertiary prevention aspect, which is when individuals are ill and sick, that we provide them with the support they need to maintain their health in the best way possible and not escalate to a crisis situation, a crisis point. And that links closely to the Care Act responsibilities that are with the council, thinking about how we prevent, reduce and delay the development of both needs and in terms of health and social care. Now, the strategy lays out some really key principles. So the idea that we focus on prevention first, we build on the strength and assets of individuals and the communities to prevent escalation. We take a whole council approach to thinking about prevention. We put in place a modern, preventative-focused, community-based and digitally enabled system to support, and we'll come on to some of the aspects behind this, but essentially to support those individuals to help maintain their own health and get access to the right services at the right time. And put a real focus on health inequalities and the gap that we see between some of our most deprived areas and least deprived areas in terms of how long people live healthy lives for. And there's I believe I'm still learning all the facts and figures about West Northamptonshire, but I think it's a 20-year gap between how long you live in good health for in our most deprived communities versus how long you live in good health for in our least deprived areas. And then finally, to be a person-centred approach, the idea that not one size fits everyone, and we need to flex and think about how we work flexibly to support individuals have the support they need to have good health. So that strategy then develops the prevention model that's outlined here, sets the different tiers and levels of approaches. The first, level 1, is thinking about those universal, at the bottom there, the universal services that are there for people before issues arrive, thinking about how we train staff to have healthy conversations every time they come face-to-face with our residents, thinking about how we use some of the assets that we've got to provide support, how we set up the right environment and work with parishes, town councils and others to have healthy places to live. Level 2, which thinks about those early intervention and emerging issues. So as things start to arrive, how do we take action early to prevent escalation of health issues and social care need? And then as we move up into level 3, we're thinking about how we act quickly to prevent that escalation, and level 4 in how we provide that crisis response. So going back to my 3 primary, secondary and tertiary, we've got the green level at the bottom being that primary prevention, so before illness starts. The yellow and the amber levels are both secondary prevention, some of it broader, some of it more targeted at particular individuals. And then the red level at the top is about delay. It's that tertiary prevention that we're trying to sort of work with individuals in crisis with. And adult social care particularly focuses on those level 2, level 3 and level 4 within there, and we'll come on to some of the sort of work that we're doing at the moment to sort of develop that. And those wider council approaches largely come under some of the green stuff under level 1, thinking about how we set the right environment for people to live healthily in. So the strategy outlines sort of a 3-pronged approach to prevention, and those are access, flourishing communities, and early detection and prevention. I'm going to touch on each of these to give you a flavour of what they're about. As you can see, they each have a lead, and it brings together people from across the council, which I'll again touch on in terms of some of the governance that we have. So if you ask detailed questions about it, I may have to take away the answers to some of those individuals to get the answers, but I'll give you a flavour of them to get you started. So the first of those is the access, resident access strategy, thinking about how we ensure council services are accessible, easy to navigate and clearly signposted to help people sort of maintain their independence and overall well-being. So really the focus of this is to put people in control of their own health and well-being. It's how do we get them to the right information quickly and effectively and get them to the right people so they get the right level of support. And that's thinking about some very technical things, which I'm not going to pretend to sort of try and describe in terms of new AI approaches and new other, how do we sort of provide information in a more automated sense to some individuals who can benefit from that, and where do we make sure people have signposted to the right conversations that they need to have with individuals to get access to other areas of services. The second part of that then is around flourishing communities. And the strategy talks about wanting to bring people together to identify local issues, devise solutions and build sustainable local action on health and those building blocks of health that I talked about previously. Now, this includes some of the work on LAPS, which we talked about a little bit before. It sounds like they're going to be very busy in the new year as they start to reform. And those labs will be taking some of that health information, trying to understand what are the health priorities within their communities. And my hope for those labs really is that they provide the community voice and community flavour of those issues to health colleagues who are developing neighbourhood plans on the similar geography. So the idea, hopefully, is that those labs can bring community voice and identify how those health issues are impacting individuals in their communities, so that we can make adjustments and think about how we provide the entry points for people into services that are based in those communities, because it might be that people in two different communities might have might on paper look like they have the same challenges and issues from a health sense, but actually their ability to engage in health services or their ability to engage in some of our preventative services relies on different approaches needing to be taken. Some will much prefer maybe a digital entry point, and how do we make that easy for them? Others might need us to be coming towards them and coming into their communities. So I think LAPs have a really important role to play alongside then influencing the new NHS neighbourhood approaches. And I know NHS colleagues are awaiting sort of the final guidance on how they develop those neighbourhood approaches. And I think someone mentioned before, you've got your LAPs, you've got your neighbourhood approaches, you've also then got those new models of care in primary care that are starting to sort of be developed in those two pilot sites, one in the north and one in the west. So there's lots of work to undertake here in terms of how we influence and think about communities and support communities to be healthy. Finally then is thinking about early detection and prevention. So how do we identify early people's needs and get them into the suitable interventions? I highlighted a couple of things that fit into this, and I might require Neil or others to talk more about Rose, because it looks fantastic, but it's not something I know in great amount of detail in terms of how we get that conversation going in terms of access to adult social care. But also in there is things like our falls prevention approach and the service we provide to support individuals at high risk of falls. How do we promote physical activity, emotional well-being, the well-being service in the council? How do we support those individuals to maintain their independence as they go through ill health or frailty, and how do we support that? And then, as we'll come on to later, that strength-based approach to how we have that opening conversation with individuals in social care to focus and understand their strengths, and how we can build our plans around what their strengths are and get them into the right services. This is also where we need to find those strong connections between adult social care and the wellbeing service and others, and public health services in our communities. So stop smoking advice, weight management advice, how do we get people connected to the right support in the right place to make an impact on their health? A bit of governance. It's always the slightly more dry, boring slide with lots of boxes on it. But the idea behind this is just to show that how prevention is embedded within the exec leadership team's transformation approach. Is identified as a wicked problem, recognising that it's not a problem that public health can solve on its own or adult social care. It requires the corporate services, communities, public health, adult social care, all coming together to think about how we can work across those three different areas to influence health. And just to finish off, I'll just touch upon, I might turn to Neil a little bit for this bit, which is that three conversation model, which I hinted at starting with that strength-based approach in conversation one. But I'm going to hand over to Neil to talk through the other aspects of that.
Yeah, so I think as David's outlined, we've got in adult social care in terms of our practice what we refer to as a free conversations model. So if you think about it in terms of that pyramid, it's been the high volume of conversations we have is around getting people access to community-based support and building on their strengths and what are the options for them in terms of that support and helping them to stay healthy and well at home. At a second level, it's responding to potential short-term changes in their condition, So we often talk about people going through reablement services when they come out of hospital because they've had a short-term change. How do we get on the front foot with that, so where people are starting to show a decline, we give them additional support that brings them back to their usual level of health before it potentially escalates or turns into something more. So an example of that would be our approach to remote monitoring in care homes. So that was using technology to monitor the health metrics of somebody through a remote monitoring platform on a day-to-day basis. And then when we could see a decline in their health conditions, that was then linked to a proactive clinical response, which gave people a level of support early and a level of intervention to bring them back up to a normal level of health, and then prevented the need for a potential hospital admission or a potential escalation in their care needs. So it's looking at things like that at a conversation 2 level, and then when we reach conversation 3, it's thinking about longer term planning that supports people with probably more formal arrangements around their care moving forward, which is our traditional Care Act assessment type work and the commissioned care and support that I'm sure you'll be more familiar with.
So that's a quick, high-level overview of prevention. I'm sure you probably have lots of questions, and I will try my best to answer some of them, and if not, think about where we can bring things back to you in the future for more detailed discussion.
Just so that we kind of set some boundaries, I suggest we go to the work programme at 5 to 8 so that we actually finish at 8 o'clock. And so we've got 15 minutes to...
I can't tell you in my time as a councillor how many prevention strategies I've sat through, but nothing changes. And there are so many areas of the council where in public health you need to be working across the board. One, for instance, is the planning department. A long frustration over getting the planners to actually buy into our prevention strategy, and that means dealing with developers in the design of estates. It means getting 106 monies for getting the big new estates to actually become a community. They should be able to, instead of having money for all sorts of spurious things that they get on 106s, they should be able to employ somebody who actually makes enables the community to come together and bring them together and set up creches and yoga classes and things, you know, that they could, that actually starts to build a community, because usually people are coming in from a long way away. They're usually isolated from their family and got children, etc. So, you know, getting the planners to actually buy into what we're trying to do, but, you know, insisting on more bungalows being built in estates so that we can help the elderly stay in their own home for longer. I don't know what happened to the anti-poverty strategy that we were all working on. I don't know, you know, it was very successful actually. We were making headway through very difficult times, particularly through COVID, but I don't know what's happened to all that work that we did and captured. And then the liaison with the health service, just to give you an example of a Kafkaesque situation that I experienced when looking after my father. He'd been advised by an OT that he needed to be referred to the Falls service. When I managed to get through to the Falls service, they wouldn't see him because he hadn't fallen. You could only be referred if you'd had a fall. So, you know, and then that happens a lot with the health service, actually getting them to be responsive on the drug and alcohol services and the mental health services. And I'm really keen, obviously keen as mustard, to try and get these new pilot schemes and the LAPs to be working, because there's so much opportunity there. And one of my big frustrations in the last iteration of it was it wouldn't work unless you had a budget. And now we at least are going to have a small budget, but you couldn't get the buy-in from the doctors and nurses unless they could see they could actually make a difference. So that's my general moan. Thank you.
We're both a bit of a pain, yeah. We have a lot of work, I think, to do with our parish councils. We have some that I have visited that are doing an amazing job for their community with the things that they're able to put on in all sorts of health and well-being ways. Parish councils do not have the same budget restrictions that we as the council have. If they said to their community, we're going to put your council tax up by £1, we're going to have this community centre that's going to have all these services that you can use, they would say yes, and they could just do it. But actually, we've kind of got a thing going on with a lot of parish councils where there's them and us. I'm speaking personally of my own one. When I did a conversation...
I'll endorse it.
When I had a conversation with them about having some sort of well-being hub, they all said to me of a man, that's West Northampton's job. And I said, don't we care about the people who live here? Because that should be what we're fostering, that those local people care about the people who live in their local area, because they know all the people that have got issues and problems and need support. You don't, but we do that live there. So I just think we need to have a whole plan on how we engage with our parish councils individually rather than go through the NCALC route, because that doesn't feed into the parish councils in the right way, in my opinion. To say that,
wait till the end. Come in, Alison. Wait till the end, and then, yes, because Alison, come in.
Thank you, Chair. I would thoroughly endorse as to what Fiona has said. I actually look after 31 parishes between three of us, but I seem to have the lion's share. That's my stupidity. However, that is the reason I joined the council, was to serve the people in the parish councils. I thoroughly endorse whatever you can do to bring this forward. You would have our support, but as per Rosie says, I've only been on the council now for 5 years, but I've had 3 prevention sessions thrown at me, which is inordinate, and I prefer to have a lot more planning sessions thrown at me, particularly when it comes to things like bungalows, which is now being wiped off the slate. And it is the one thing within villages particularly, and actually the 3 of us do serve in villages and two larger townships, is that we know what we need, and if only somebody would ask us the requirement, as you are today, and we're being able to feed into the midst, it would be worth 1,000 words. Thank you.
So, yes, Andrew, come in.
Yes, sorry, I hadn't got a lot of questions because there's a lot in it, and I'm still thinking about all the stuff that you've given to us, and hopefully you're going to circulate the presentation. But the one bit that resonated with me, which is different to what other people have been talking about, is the accessibility side of things, particularly when you talk about digital. Because unfortunately we've got a lot of people who aren't digital, they're more analogue, and my parents are in that category. And I have experienced from a personal point of view with them and also with constituents, people coming up against barriers trying to access services because they're being told you have to go online or you have to fill out this web form. And in fact, I think we've got a debate coming up for council about blue badges, and that was one of the areas that I found residents were having difficulty because there is no paper application, you have to go online. So I do think we need to have a look at that, and be interesting to explore that a bit more as part of the whole prevention strategy, in terms of, are we really being accessible to everybody that we need to be?
I'd like to come in to address that point. I think within the laps that we're bringing out, it's going to be included in there, being able to have whoever visits the families at home to support them with the access to services in a way that suits them. It's something we're working on, but we are thinking of that.
I think it would be really useful, maybe not the next meeting, because I think we'll be doing the Care Quality Commission report then, but maybe 2 meetings on to look at
Shall I have a go at answering some of those?
Yes, I think you need to answer that. But then I think Richard will have to draw out what are the action points that we can take, because I think as a committee, as a scrutiny committee, we've got a role in as you said, getting away from the talking. What are the action points? What are the hard issues that we as a scrutiny group need to be looking at to try and unbone where it's bunged up and kind of change from talking about prevention to actually doing it?
Yeah. So 2 months into the job, I think you've now set my work plan for the next 10 years. But I'll try and run through a few of those areas. So, Councillor Herring started off, we're talking about some of the planning aspects. I suppose all I can at this stage is I can't provide you the answers to it all, but I can provide you some reassurance around how in public health we do have a team member who sort of provides public health advice into all the developments that come forward as to how they're meeting some of our, from a health perspective. And also we've got the local plan coming out for consultation soon. So it's important that people engage and we get engagement in that plan to think about how it can influence health. And we've already worked with the planning team to think about some of the most direct areas of influence on health in terms of hot food takeaways and the prevalence of those in certain areas where we're seeing high levels of overweight and obesity, to see how we can influence the environment as we move forward. But there are other things that, as you say, you know your residents about and what's influencing their health that you might want to sort of think about in that consultation.
Just in terms of the local plan, one of the things that we had asked is that when they are planning these big developments that they do include local ward members, and that would link in with the LAPS as well, because they know what the local ask is.
Definitely.
So if that can be sort of added in somewhere, if somebody takes that on board, because then the two elements would be working together.
Yes. So I'll say I can reach so far in terms of my public health influence, but we might have to bring back colleagues from planning to talk about some of those specifics and how we think about that. I think in terms of the anti-poverty strategy, there is still work underway. The Household Support Fund, for instance, and has been allocated recently, and getting money out to community groups and also to individuals as part of that Household Support Fund is one aspect that has sort of been continuing. But
can I just add one frustration that we had going forward, and just updating other councillors with the Household Support Fund, that they were giving out vouchers for supermarkets, but they were not stopping them spending all that money on booze and fags.
Okay.
And that was, some supermarkets did, but some supermarkets did not. And we had evidence that that was happening, and that money was to support the food for families and young children. So it should be an absolute criteria that when you give those vouchers out to those to those communities that are running those funds, that they cannot spend it like that.
Okay, I'll take that away. Did you want to come in? Sorry.
Say something. Sorry, I just want to say something quickly on the back of that. I don't know in any strategy or where we are as a council in like education of families. Obviously, we all know the cost of living has gone up tremendously and it affects us all. But, you know, in terms of education, in terms of maybe healthy eating courses, cooking courses, you know, how to stretch food, you know, bulk things out with pasta. I haven't got the answers, but just as an example, where we are or have we thought of anything like that? And I thought of that after you said that, Councillor Heaven, about the, you know, where money has been spent.
I wonder whether we need to, on our work programme, just pick up the anti-poverty strategy at some stage, either this scrutiny group or your children's scrutiny group, one or the other, or maybe both.
So just come back on that. So there are services that we do have, such as Grow Cookie, which go out into communities and look about how they can support families think about cooking and growing food, etc. So that we do have some of those sort of functions there. ageing well as an agenda that's jointly with the NHS as well, thinking about, yes, we have the falls prevention service, but we also have those sort of functional physical activity classes that alongside the NHS, so there may be some exploration there in the future around that ageing well agenda with the ICB. Town and parish councils, Councillor Bacon and Councillor Eastwood, was just that I was at the Town and Parish Council conference. It's a new thing for me. I've come from working in a city before, so it's a new area for me to sort of understand. Again, we do have a public health officer who works with some town and parish councils, and there've been a couple of who have developed health and wellbeing plans, and maybe we need to try showcase some of those best practice to sort of how we can spread that. And then Councillor Simpson, I completely agree around the idea around digital literacy and how we make sure that we're supporting people either through how we both provide that support in the places like libraries and other places to make sure that people are able to understand and get access to computers and internet and the other aspects, but also thinking about how we provide services in multiple different ways. And I think that's part of what the resident access strategy tries to do, which is think about, yes, there's digital, and I always talk about the magpie effect, which is not always go to the shiny thing. Sometimes the simplest thing is easier, and how do we sort of build that in? And then the final bit around barriers to prevention, some of the silo working, I've not got all the solutions to that, but what I would say is this work in particular brings together different parts of the council to try and work together. So whilst it's not breaking down every silo that there is, it's starting to break down those walls and think about how we can work across each other to think about prevention differently. I'm all for thinking about those pre-contemplators and how we change and get them ready to change. Some of that comes down to that conversation one we talked about, is how do we recognise people's strengths and how do they access us, that first conversation we have when they access our services. But I'd also argue that behaviour is broader than just individuals changing their behaviour, but actually how do we create the environment that makes things the default option? So how do we make, we've got the active travel strategy coming up soon, how do you make that the default option for people rather than jumping in their cars if need be? And so there's a broader agenda that links to it, but I completely get where you're coming from. Now that's a whistle-stop answers, but
just add another one with the planning, and the local plan was getting them to actually accept that we have an absolute zero tolerance for fast food outlets on school routes.
So there is something which you'll see in the local plan which is related to that, which will come out for consultation in the new year, I believe, but I'll double check.
Right. Thank you, David. Thank you, everyone. I think we could go on much longer on this, and I think I don't know whether, Richard, have you got an action point that we can take out of this one in terms of taking this forward?
Thank you, Chair. I don't know whether you want me to summarise now or move into the work programme and summarise how we progress forward with this work.
I would say let's move into the work programme, and you can bring any items from that into that.
Okay, so yes. We'll move into the work programme then, Chair. So, is everybody... Okay. So, obviously our next meeting is on the 20th of January. We've got the CQC outcomes, which will obviously be a fairly substantial item for the committee. We've got a session with the Cabinet member on priorities and challenges relating to the delivery of adult social care. So a lot of the points raised tonight can be brought up in that session as well. And we've also got the workforce planning item with the requested information that we've covered off this evening as well. So that leaves us with 3 items then for the 20th of January. Beyond that, we have on our work programme, just picking up this issue of prevention, we had local area partnerships.
Right. I think that I'm keen that we try and merge that with the health service changes so that we have a discussion with our health partners and really understand how that is going to work, how that is going to be taken forward.
So that could obviously include local area partnerships and obviously the lower level service provision as a future work programme item, and the inclusion, as discussed earlier, of the anti-poverty strategy as a possibly a cross-cutting theme with the Children's Committee to look at that jointly and how prevention is embedded across adults and children for that. So that takes us up to January's meeting, and sort of beyond January, and at January's meeting probably we'll have to have a wider discussion on the work programme. Obviously, myself, Wendy, yourself and David met with Melanie Williams, who's the new Executive Director of People Services, and started that conversation off. And obviously, Melanie's got some ideas as well to put forward into that. So I think what we could do at the next meeting as well is, rather than have the standing item of review of committee work programme, we could have it as an actual review. And then we're planning the work programme almost for the rest of this municipal year and the following year as to how we can embed these themes further. That summarises it from me, Chair, if everybody's happy with that.
Any comments on that? I mean, I think if between meetings you've got an issue that you think we ought to be looking at, do feed them into me, because I'm meet with the Executive Director and with Democratic Services team. So we could, it seems to me that the programme is going to have kind of longer term goals and then kind of shorter term goals, and sometimes ideas usefully feed in and kind of make an item more concrete, because we've got a specific thing of concern to the committee. So that will work best, and Richard is going to...
Thank you, Chair. Obviously, it's ultimately your work programme. So something that we suggested amongst ourselves as officers is, obviously we've got a number of bits on the work programme, but we could include a column that suggests desired outcomes as well. That's currently not there, so it would give the... It would almost embed the principle of task and finish into your work programme in the items that we deal with on a standard basis.
Just very briefly to remind you, supposedly, and it may not happen, on the 19th of January we vote through this new CEO, and that may alter quite a lot of perspective.
Right. we will cross that bridge when we get there, I think.
Know, but
yes, do, Richard.
Thank you, Chair. The appointment of the head of paid service would not have an immediate influence on this work programme, what this committee wants to look at. Regardless of which policy direction the council changes, this is your committee and your work programme, and the scrutiny that this committee undertakes really is down to the folks around this table.
Right, so the other area where we do have a role is the Place and Resources Scrutiny Committee will be holding a workshop session on the 2026-27 budget in coming weeks. It's really useful if we are all, it's an online session, it's a really useful session for us all to be involved in. It does mean that there will then be the opportunity to look at different aspects of the areas of budget that we have an overview of, and if more of us who are there will mean we can have a greater impact on it. So I would encourage you, when that gets advertised, which will be, I think, early in January, does that meeting take place?
I can provide the dates for you now, Chair.
Yes, that would be really useful. It's the one that Ian McCall chairs. Yes.
It is early January.
Yes.
The exact date is, there is one on the 14th of January at 5 o'clock.
Yeah. So that's 14th of January at 5 o'clock, and I think that we can have a useful input into the discussions there. Right. Any other business for the meeting? So do we formally need to agree the work programme as proposed by you, Richard, at this point?
It would have to be proposed and seconded by a committee member and voted on, but we're just reviewing the committee work programme and essentially approving the items for the next meeting.
Yeah. People in agreement with that? Yeah.
Yep.
At which point I've lost my agenda for the evening. But I think, unless there is any urgent business, I haven't been informed of any, can I thank you very much for your contribution to the meeting and your attendance, and I can close the meeting at 8:07
Well
p.m.
done. Thank you.
Thank you.